Please join me in welcoming ER physician and best-selling author of The Casino Shift, Stories from an ER on the Edge, Dr. Brian Goldman. Welcome, Brian.
Hi, Teresa, and thanks to all of you from right across Canada who are taking time out in the middle of a busy day to hear from me. And so what I want to do is talk a little bit about the book, but I also want to talk about what's really going on in emergency medicine, and then I'll talk about the power of storytelling, which is what I do in all of my talks. And if you listen to White Coat Black Art, it's a staple of our radio show. The question I'm being asked, Teresa, and in every interview that I'm doing is, what the heck is a casino shift? So I thought I'd begin by explaining that. A casino shift is a split night shift. It was borrowed from people who work in the casino industry because, like healthcare, it's a 24-hour-a-day business, especially these days. It was first implemented in and much preferred at the QE2 Health Sciences Center in Halifax. It's a split night shift that usually begins at 9 or 10 in the evening and goes from 3 or 4 to 3 or 4 in the morning. And then there is, on the opposite end, somebody who's arriving at 3 or 4 in the morning and working until 9 or 10 in the morning, and then having the rest of their day. And you know, you might think that it's really disruptive, but it turns out that it's far less disruptive than a full-on night shift that might begin at 11 p.m. or 12 a.m. and extend until 7 or 8 in the morning, especially if you're doing a string of those night shifts. If you do a bunch of those night shifts in a row, then you get zero time in the daylight hours. You're sleeping that entire time, and you're up all night. And that's what seems to be debilitating. When you work a casino shift, yeah, you might be sleep deprived, but you don't have that mental fogginess that you have that progressive mental fogginess when you tend to work several night shifts in a row. So basically, you might be a bit sleep deprived, but you have at least 4 or 5 or 6 hours during the daylight hours when you can be out and about in the sunlight, and that helps to resynchronize your circadian rhythms. And our colleagues at QE2 Health Sciences Center, once they implemented casino instead of night shifts, there was no looking back. That's what they wanted to have. Now, when I was asked, do I want to write a sequel to my first book, The Night Shift, my first thought was, hell no. Who wants to write a sequel and redo what you did before? But it turned out that it was a marvelous opportunity to give a state of the nation on emergency medicine today. You know, given the fact that it's a fire hose, there's a fire hose of information that we're hearing, much of it bad, about what's going on in the emergency wards. You know, 15 years ago, I talked about hallway medicine. Now we're talking about waiting room medicine, where some hospitals have on average 50 or 60 patients in the waiting room, 50 or 60 souls like you and me, sitting in chairs. Some of us might have smoldering ectopic pregnancies or appendicitis or aortic dissections, an aorta that's about to blow if we don't get to it in time. And my heart goes out to those brilliant triage nurses who have to keep track of all of us sitting in the waiting room. And, you know, what's changed about the past is that the waiting room used to be a dead zone as far as medical care is concerned, and we've adapted. Now we have side rooms adjoining the waiting room where we can swing patients in and out and do quick assessments. We're doing histories and physicals in private, but in those side rooms. We also have phlebotomists who are doing blood work and EKGs. And sometimes it's not 50 or 60 patients. Sometimes it's as many as 100 more patients. I want you to imagine that picture of patients and family members cheek to jowl in the waiting room, hoping that their loved one gets brought in before it's too late. There are many reasons for the crisis in emergency medicine. And I talk about these in the book at length: the lack of hospital beds, the lack of long-term care beds. So we have so many admitted patients on stretchers in the emergency department that there's that fewer stretchers available to bring patients in from the waiting room. Plus, we have this continuous inflow of new patients, critically ill patients arriving by ambulance. Some of them are walking in. And we also have unhoused patients, patients with mental health disorders, patients with substance use issues like opioids. We also have a huge influx of what we call unattached or orphan patients. There are as many as 6 million people in Canada, 2 million, over 2.5 million people in the province of Ontario alone who don't have family doctors. And what are their options? One option is to try to book an appointment at a walk-in clinic. If you do, you're going to find that within an hour of the walk-in clinic opening, up by 8 or 8:30 in the morning, all the slots are full, and so your only option that day would be the emergency department. Other issues that are facing unattached patients: inconvenient prescription renewals, no counseling for non-urgent mental health issues, no scheduled immunizations, which means they're going to be coming to the emergency room. They're going to be more likely to have complicated respiratory ailments like RSV, COVID, and influenza. And they don't get access to cancer screening, which means that we're seeing an increasing number of patients coming to the emergency department with cancer. Some of them are in their 20s and 30s with lung cancer. Some of them are people who've never smoked. We did a show on White Coat Black Art recently about never smokers getting lung cancer. Yes, it does happen. And increasingly colorectal cancer as well. So they end up in the emergency department. And they don't just have type 2 diabetes or high blood pressure. They have type 2 diabetes and high blood pressure that's been unmanaged for a decade or 15 years or more. And that means they come in with advanced kidney disease or eye problems or cardiovascular disease. And many of those patients who do come to the emergency department with cancer don't have stage 1 or 2 cancer because they didn't have a family doctor to pick up on it early. They now have stage 3 or stage 4 cancer. And, I want you to imagine in that cheek to jowl emergency environment what it's like to try to find a private space to tell a family that their loved one has cancer, and it's advanced, and they're going to need immediate treatment to prolong their lives, even if the cancer is incurable. So there are those problems. But in the book and on White Coat Black Art, we've gone seeking solutions. So what are some of the solutions? Certainly across Canada, we have new medical schools, we have nurse practitioner-led clinics, but we also need to look at policies and procedures in other countries. And I want to introduce you to what's going on in Denmark right now. If you don't know this, I went to Denmark last year. I travel for the show, and I bring those insights to our show, to my books, and to the speeches that I give. And I want to introduce you to two Canadians who are currently living in Denmark, Emily Ritchie and Caroline Berard. And what they discovered, they're holding the equivalent of a social insurance card. And if you look closely in the upper right-hand corner of their social insurance card, we've deliberately fuzzed it out so you don't have their identifying information. But trust me, what's on that card is the name of their GP. It's there. It was provided for them. They didn't have to go searching, begging, borrowing, stealing family doctors. Do you know somebody? Is anybody taking patients? And they have other advantages. If their doctor, their GP as they call them, refers them to a cardiologist or to a gastroenterologist or a dermatologist, they don't go through referral hell. They book their appointments online. Unlike Canada, consultants can't politely decline consultations. And so that's a major difference. It gives choice. By the way, if patients who are assigned a family doctor based on geography don't like their family doctor, they can request another one or they can go looking for one themselves. So they have advantages and they have choice. One choice they don't have that's really, really interesting is that they cannot access the emergency department themselves unless it's a flat-out emergency. So unless they're brought by ambulance because of an accident or a life-threatening illness, they can't just select the emergency department, unlike Canada, where people select the emergency department for good reason because they don't have other access to primary or other kinds of care. The only way they can get to an emergency department, well, there's three ways. One way is to have a flat-out emergency, which you don't choose. A second way is if your family doctor makes an appointment on your behalf to the emergency department, or in the after hours environment, so your family doctor or your GP in Denmark has signed out to an after hours urgent care system. You call your family doctor's office. They immediately forward you to a call center which is staffed by physicians and other providers. You get your call screened, and then a triage history, and then you're connected with the primary care physician on call, who can do one of three things: treat you, send you back to your family doctor, or make an appointment on your behalf to the emergency department. And that's how you get to an emergency department. So they seem to have a system. And I can tell you, in Canada, we would think, well, if you don't have access to the emergency department by choice, then patients must be dying left, right, and center. Well, they aren't. Their system seems to work just fine. So I do think that we need to take their example. Denmark, like other countries in the EU, has a mixture of public and private health care. 99.5% of citizens are listed with a specific GP. That's what they call them based on geography. And they work in teams. They don't have solo practices. They're group practices. They work alongside learners, nurses, midwives. Midwives don't just do antenatal or prenatal care. They do postnatal care, pediatric care, and routine gynecology. Like Canadian GPs, the ones in Denmark complain about paperwork, but they're happy by and large with their jobs. They're well paid and they're on salary. They're not on fee for service. In my book, The Power of Teamwork, I talk about the benefits of teamwork. And teamwork is not a phrase. Teamwork makes the dream work. There are some important aspects to teamwork. You have to have everybody on the team knowing their role. It has to be distinct from one another. You have a team leader who knows the strengths and the challenges of each team member and maneuvers people around to show people at their best, to not put them into situations where they're going to fail. And if you adopt a true teamwork model, the benefits of teamwork will include a more accurate diagnosis, better treatment, better productivity. You see more patients, you feel happier, and you actually have lower rates of burnout compared to groups of individuals who aren't working in a teamwork model. And I say a lot more about that in my talks on teamwork, and I've given many of them in the last few years. They seem to be a particular favorite with financial institutions and people who want to highlight the importance of good management to a functioning company or a not-for-profit or for an institution like a hospital. I also like to talk about options that are controversial. And among emergency physicians, some emergency physicians, virtual emergency medicine is a very controversial topic. I don't think it's controversial in those places where the choice is to have a virtual ER or no ER at all. And that is taking place in rural and remote parts of Atlantic Canada and British Columbia. And, you have in those emergency departments, family doctors. There might be 7 family doctors who are trying to cover the 168 hours a week, week after week after week of the emergency department in that particular small hospital. And, in British Columbia, they're giving them an occasional night off, maybe once a week. So the way it works is that the family doctor is on call to the hospital, but goes home at 8 p.m. And from that point on, for the next 12 hours, you have a virtual emergency department. What happens is that patients line up in the usual way. They sign in. They're seen by a triage nurse. They get a nursing history and physical blood work. They get an EKG. They might get an X-ray if that's appropriate. And then they're plunked in front of a tablet or a computer monitor, and they can talk to an emergency physician, board certified, who might be as far away as 1,000 kilometers in another part of British Columbia. They take a history and physical. They recommend further treatment. And again, they're monitoring this system very, very carefully to make sure that patients aren't dying because they're receiving compromised care. I think one of the key messages that I like to promote is the idea that we need to be flexible and consider new ideas, because without those new ideas, we are not going to be able to have a functioning emergency department. The other thing I think we need to consider is, I'm not endorsing private for-profit healthcare, but I am here to tell you that private does exist. For example, in the province of Quebec, there are family doctors where you, for $150, can get 15 minutes of their time. And that system is booming. That system has not just rich people paying for primary care. You have single moms who are paying for primary care because the alternative is to spend 18 hours in an emergency department with all the risks attendant in that. And we have private joint replacement. Linda Slater was waiting more than 2 years for a knee replacement in the province of Alberta, and she ended up draining. She and her husband agreed that she needed to drain 30,000 of their retirement savings to have a knee replacement operation done in Ontario, and she has absolutely no regrets. And I went to Germany, and we haven't had that show. In fact, I'm writing the script for our upcoming White Coat Black Art. The Charité Hospital in Berlin does more hip replacements than any other hospital in the world, almost the largest number of knee replacements in the world. They have a fusion of public and privately funded joint surgeries. Private pay gets you a better hospital room with better amenities and a better view and nothing more. Maybe a little better access to rehab care. It works in Germany because they have a higher tax base and enough orthopedic surgeons to supply both systems, so you don't have a net drain of qualified practitioners from the public to the private system, which would result in longer wait lists. I want to close with a couple of stories. We do topics on White Coat Black Art, and I discuss topics in my talks and in my books, but I don't just do the topic. A topic is not a story, and I believe that a story is the best way to get people to talk about something in a topic. And one of my favorite stories from White Coat Black Art and in my books that I like to talk about is this story. You may have heard of it. Man Googles rash, discovers he has a 1 in a million rare disease. That's Ian Stedman and his daughter Leah a few years ago. For more than 30 years, Ian lived with an unidentified debilitating condition causing terrible joint pains, rashes, and headaches that were triggered by cold air conditioning, and being out in the cold. And it forced him to limit his time in school and his time at work. And he learned to live with it. And over the course of the first 30 years of his life, he visited hundreds of doctors, did their tests. And when their tests were negative, he was sent on his way. By age 32, he gave up the search and learned to accommodate to his condition. Then he got married. Then he had his daughter, Leah, and within 8 or 9 months, realized that she had exactly the same symptoms as he did. And then he dedicated himself to finding the name of this diagnosis. And he realized two things once his daughter was born and had the same symptoms. First, it was a rare disease because no doctor had diagnosed it. And second, it had to be inherited because both he and his daughter had it. Turns out his mother had it too. So by this point, he was a graduate lawyer and used his legal mind for a more systematic search. He asked his family doctor to send him to specific specialists to rule out specific conditions. He got the email addresses of rare disease experts in Canada. He joined a group of families who were searching for causes of rare diseases. He read hundreds of patient stories and searched thousands of photos online. And then one night in 2013, he searched and searched and searched thousands of pages, and he landed on one page. He said, and I'm quoting here, "I saw my skin, the red eyes, the headaches, the fevers, the arthritis. It was my issue. That was what I was looking for." And it turned out that this person who had told his story online had Muckle-Wells syndrome. And he contacted Canada's top expert in Muckle-Wells. He's now 85, is Ron Laxer at Sick Kids. At 2:15 a.m., he emailed Ron Laxer describing his symptoms and said, "I think I've got Muckle-Wells." At 2:30 a.m., Dr. Ronald Laxer replied, "I think you may be right. Come on in for testing." And he was right. And Ian became the 11th Canadian diagnosed. Leah is the 12th, and Ian's mother, the grandmother, is the 13th. And I'll ask you, did you enjoy the story? What was it about that story that made you like it? I'll stop here. I'm sure you've got questions. I hope that you've enjoyed this little presentation, and I hope I've given you something to think about.
Thank you for this, Brian, and leaving us with that thought starter and showing how kind of the facts and information really kind of hit home through the power of story and our humanity. And overall, from this presentation, thank you for helping us understand the value of teamwork and being flexible and considering new ideas and triaging when you have multiple priorities. I can't even imagine what it's like in the ER that way. We do have some questions coming in, so I will go over those with you, just pulling it up here. Um, Michael has two comments. One, the punchline to Ian's story. It sounds like he's on a biologic med and is well. So,
That is right. And it's an expensive medication. And he, that's another part of the story. There's yet another part of the story too. Ian has become a dedicated advocate of more widespread genetic testing with appropriate privacy controls. He's also a proponent of AI and using AI to diagnose rare conditions. And another interesting tangent to the story, extension of the story, is that he has been collaborating with Michael Brudno, who is one of Canada's top experts in AI, applications of AI. And Michael Brudno was working on an algorithm and asked if Ian would supply his clinical notes to feed into the algorithm. And so he did. And the end result is that by using an AI algorithm, Ian might have been diagnosed after 8 appointments, just 8 appointments with his family doctor, not 30 years of searching.
wow. Yeah, thank you for that. And I know you're trying to squeeze it all into a short presentation, but that's some of the depth that I know you can go into further. And we've got a question also about you touched on learning from other industries and best practices, well, within a similar industry. And there's a question about can you comment on the cost per capita of Denmark's system? The questioner is saying, I bet it's not only better, but cheaper overall. Do you know?
I don't have the exact
Okay.
figure, but I think it's really important to stress that Denmark has a broader tax base and they have higher tax dollars. And I want to, there's an important point here. I don't think we should be like Pollyanna here or assume that the grass is greener on the other side of the fence. There's a really important point to make here, and that is that in this world of tariffs, in this, with questions about the relationship between the United States and NATO, countries in the European Union are ratcheting up their defense budgets. And I have no idea if they have the resource. I doubt that they will have the ongoing resources for healthcare that they have today if they have to increase their defense budgets up to that 5% mark that they are aiming towards. Oh,
Okay.
one thing I can tell you what about Germany. Let me tell you about Germany. The cost, I mentioned that the cost of a hip or knee replacement in Canada is $30,000 Canadian. The cost at the Charité Hospital is between $12,000 and $19,000 US, which is no, sorry, $10,000 to $15,000 US. Depending on the exchange rate, that would be between $19,000 and $24,000 Canadian. So they are able to achieve private joint replacements at a cheaper cost than Canada because they have competition and because they have they have a larger number of healthcare providers who are competing to provide the services.
Got it. Thank you. You've touched a bit about geopolitics, and we have a question from David. The question is, why don't we think outside the typical political box? Will we ever learn to learn from other experiences? And certainly some of the examples you gave covered that, but any thoughts connected to
Well, you know
politics?
what? My short answer could be no. Um, but you can be an optimist or a pessimist here. I think that there's value to you. There's value to Canadians in traveling to other countries and seeing best practices elsewhere. And I'm going to continue to do that, whether we have the ear of politicians or not. I will say this. I have very conservative colleagues amongst some of my colleagues who have ascended to leadership in healthcare, in emergency medicine in particular. And in the last few weeks, I have been very surprised to learn one of them in particular, a very high placed person who has had the ear of the Ontario government for a long time now, for decades, approached me and said he wanted to have a coffee to talk about mandatory enrollment in primary care in Denmark and in the Netherlands. So that tells me that there is a kind of a breath of fresh air. There is a desire to consider new ideas. So I remain optimistic.
Thank you. And perhaps one last question about prevention and and kind of dealing with things upstream before they become a challenge. And that happens in healthcare. It happens in organizations. Can you speak to that?
Yeah, don't get me started. Why is preventive care treated as an uninsured service, so that private clinics can offer preventive care without running afoul of the Canada Health Act? Not that the Canada Health Act is the last word in preventing abuses of the system. Just check Quebec. Quebec pays its fines and is quite happy to allow primary care, uh, you know, uh, private pay primary care. You are absolutely right that we need to be thinking upstream. We need to be thinking, what are the quicker and easier ways where we spend a fewer number of dollars upfront and get a bigger bang for the buck later on. And so we should have preventive health care uh, paid for, and I would argue mandatory, potentially mandatory, that you have to at least learn about preventive health care, whether you ascribe to it or not. There are ways of incentivizing people to participate in primary care. The insurance industry has been doing that for decades, and I'm all for it.
Thank you. Thank you very much. And speaking of a bang for your buck, I'm going to do the book draw now, and one of our viewers will get that. So let me just share my screen for a minute here. We've got all the RSVPs here in our wheel, and I'm ready to spin and see who wins a copy of your book. We will follow up and ensure that we've got a mailing address to send the book to Andrew. Congratulations. And overall, thank you to our audience for joining. We hope you found this session insightful, and we welcome the opportunity to bring Dr. Goldman's talk to your audience where he'd customize to your needs. And for clients who typically need multiple speakers in a year, we can also bring an in-person version of a speaker feature like this to your event team's office. So just ask us about this. Our next webinar, this is part of a series, will be on Wednesday, April the 1st, focused on AI and digital transformation with Jim Harris, who's recently returned from Davos, Consumer Electronics Show, and more with the latest on AI for your organization. Thanks again for joining. Have a great afternoon, and hopefully we'll see you next time. Take care.